It's important to realize that we've had a lot of different sources of rules regarding COVID-19, airborne infectious diseases, and pandemic. So I'm going to be speaking on a fairly limited subject, which is the new ETS. It's been out for about a month now from federal OSHA. But I think before I jump into the presentation, because I have a few minutes, I'm just going to go over kind of the timeline from my point of view here in Michigan. So when the pandemic started, the governor issued a series of executive orders aimed to protect various entities in the state during the pandemic. The Supreme Court deemed those unconstitutional as an exercise of her powers. She then relied on the administrative agencies in the state, such as DHHS and MIOSHA, to institute emergency rules or epidemic orders underneath their administrative powers. So these are extremely unusual rules, regulations, and laws. In the 50 years of OSHA, I don't believe they've issued another emergency temporary standard. So we are in somewhat uncharted waters when it comes to the legality of promulgation of the various rules. For any of you who have a little background in law, most of these regulations come out underneath the Administrative Procedures Act, which allows for notice and comment by impacted parties. That phase was put secondary. So they made the rule, and currently now is your opportunity to comment on. So if you have any thoughts on what you might want changed in future permanent standards related to this, I would encourage you to send that feedback to federal OSHA. We have a system of federalism. So the states can either A, use the same rules as federal OSHA, or B, provide more protective rules. The COVID-19 emergency rules that MIOSHA put into place last year were far more protective than the current federal emergency temporary standard. There was a decision made here in MIOSHA to end our rules and simply adopt the feds. So the good news is, for those of you who have operations in multiple states, the rules should be the same in other states as they are in Michigan now, which makes it a little bit easier for regulatory compliance. The bad news is I feel the ETS missed a lot of hazards and a lot of impacted parties and is not as protective as it could be. So I'm going to try to pepper in a little bit of that as I go through the presentation. I'll make it very clear what's required and what is my advice or best practices or personal thoughts. So let's get into it. What we're going to cover today, and hold on a sec, I got to get this, there we go, get this picture of myself a little smaller. All right, so what we're going to cover today is where the emergency temporary standard is currently. We're going to go over just a few important definitions that we need to have the rest of the conversation. We're going to go through kind of the scope of the rule, who falls into it, and then we'll cover who falls out of it. We'll talk about the key elements that you need to incorporate underneath the rules, essentially what you have to do, what you should be doing currently, and we'll end up looking at some resources, and that's where we can spend a lot of time if people have questions. So let's get into it. The emergency temporary standard, as I stated, came out of federal OSHA, was posted on June 11th and became effective June 21st. There was a lead-in for compliance. They gave employers some time, not much, to review the rule and come into compliance with it. That compliance date has passed. It was July 6th, 2021. The ETS is a 6-month rule. So since it took effect June 21st, it's set to expire January 21st, 2022. I would not hazard any guess as to what might happen on January 21st, 2022. I think it's going to be, as it has been, very much a function of where the pandemic is at on that date. You might see a permanent rule on this topic, or you might see no rules on this topic, or you might see another extension of the emergency rules. So just a little note on this picture here, you'll see a couple healthcare professionals putting on PAPRs, powered air purifying respirators. And the person putting them on them is wearing a a face mask, a surgical mask. So it looks like they're getting ready to go in and help somebody who may have suspect or confirmed COVID-19, and they're wearing a high degree of respiratory protection. So what are some of the most important definitions? There's a lot of definitions in the standard. Not all of them apply to all employers. I don't have a good grasp on necessarily who all the participants to this training are, so I've just taken the ones that really apply to everybody. The first definition is healthcare services, and it's a very limited one. The thing that I like to focus people on is the fact that it is by a professional healthcare practitioner, okay? So the actual definition is a little bit longer in this one, but it's essentially services provided to individuals by professional healthcare practitioners. The broad definition, though, is healthcare support services. If you read the definition of that, it's services that facilitate the provision of healthcare services. That's a lot. There's a lot of services that facilitate the provision of healthcare services. They give some examples in the next section, such as food preparation or equipment maintenance or laundry. That's a non-exhaustive list. The actual scope of support services are very, very broad. And face mask. Face mask is a surgical medical procedure, dental or isolation mask that's FDA cleared, authorized by an EUA, or basically offered, distributed in an FDA enforcement policy. KN95 respirators were being used underneath an FDA EUA that expired. So a KN95 respirator is no longer considered a respirator or a face mask. You should be very cautious of using KN95 respirators. The scope and application initially seems very broad. It applies to all settings where any employee provides healthcare services or healthcare support services. So if you're doing something that facilitates a professional in caring for an individual, you fall into the standard. It is a settings-based rule. I've seen a lot of misinformation online and elsewhere that says this is a rule that applies only to healthcare employers. That's incorrect. It applies to many employers outside of healthcare. It is a setting-based rule akin to confined space or one of our air contaminant standards. So just to flesh that out for you, if you have employees of multiple employers in one setting, and one of those employees is doing healthcare or healthcare support, all the employees in that setting fall into the ETS. So if you have a construction contractor who's laying electrical conduit in a hospital hallway, that contractor falls into the ETS, and it gets, and it expands out from there. So I think my first issue with the ETS is it's really misnamed. It does not apply solely to healthcare. It applies to any employee who performs work in a setting where any other employee is doing healthcare or healthcare support services initially. So as you can see, that's a very broad definition. And what the standard does next is it cuts the lion's share of employers back out of the definition. So most employers look at the rules, say, okay, I'm going to have to comply with this rule. They look at the next section and they say, oh, actually, it looks like I don't have to comply with this rule. So I'm not going to read all the exemptions to you because I think that's a little unnecessary. But if you read them to yourself right here, anyone who falls into these exemptions no longer is within the ETS by definition and does not need to comply with its requirements. So I guess to pick out a couple of these, let's talk about number 3, non-hospital ambulatory care settings. What are we talking about there? Urgent cares, dental offices, sole doctor's offices that are located in a commercial office suite, things like that. If Patients and any other non-employee are screened prior to entry, and screening is minimal. Screening can be verbally asking them questions, basically just, a telephone call prior to the appointment to make sure that they are not experiencing symptoms, haven't been in contact with the known suspect case, all the questions we're getting used to asking, and not permitted to enter. That second part's very important. If they say, yes, I have a fever and a cough, but I don't think it's COVID, they can't come in. By definition, they're a suspect case at that point. If they are not permitted to enter, if they fail the screening, you're out. So right there, you can imagine, once you have that screening protocol implemented, most healthcare employers, non-hospital ambulatory care, fall out. That's in my opinion, the bulk of real NAICS code healthcare employers. What if they are in a hospital? Number 4. So basically, if they're in a well-defined ambulatory care setting, they're in and out, they're outpatient, and they are in a well-defined setting. And that's where a lot of people have questions. What's a well-defined setting? OSHA hasn't given great information on what makes a well-defined setting, but I'll let you know what it is. It's an area that any person coming into would be aware is separate from the COVID treatment area, that people who are suspect or confirmed COVID cases are not to enter. It is illustrated by signage. It is trained to employees, is made clear to non-employees. And honestly, I'd like to see some kind of actual barrier. So instead of an open doorway, a door that you have to come through, and on that door is the sign, something like that, a very well-defined area. Certainly an entire separate wing, a separate floor, something like that could be a well-defined area. If you're a well-defined hospital ambulatory care setting, all your employees are fully vaccinated, so they've had both their doses and it's been a couple weeks since they received the last dose, and all non-employees are screened and not permitted to enter, you're outside the rule again. So in these non-intensive care, wings of the hospital, if it's the radiology wing, if they can somehow avoid having COVID positive people come in there, patients come in there, and all the employees are fully vaccinated, you're outside the ETS again. So you can see the federal government is trying to push employers to have their employees be vaccinated. That's something really big that came out in this rule, that encouragement of vaccination of employees. And I'm not going to go over all these on here, but essentially, if you fall into one of these exemptions, you're outside the rule. And to flesh this out, OSHA provided us with a PDF flowchart on their website. When I finish my presentation, I hope to walk you through that website and point out where some of the resources I talk about are. We should have plenty of time to do that. But we're just going to kind of take this flowchart and break it out and just run through it. So the first thing I would do if I was concerned about whether or not this applies to me is go through this process. And I know that you can all read a flow chart, but I think speaking through it may trigger some questions for our Q&A session. So I'm going to do that. So is your workplace a setting where any employee, not your employee, any employee provides healthcare services or healthcare support services? So if not, the ETS doesn't apply to your workplace. That's the definition of the ETS right there. But if it does, if you do provide healthcare support, you got to move on down. If it is a non-hospital ambulatory care setting, all non-employees are screened prior to entry, and people with suspect confirmed COVID-19 are not permitted to enter, right? If you are a dental office and you don't need to provide emergency dental services to individuals, if you're not able to, stop people from entering for any reason, then you are still in the standard. But if you are able to exclude those positive cases, if you're non-emergency, basically, you are outside the standard and it doesn't apply to your workplace. So if it's yes to all the above, it doesn't apply. But if any one of these is a no, you got to move on down the flow chart. And like I said, people are really good about the first two. It's the not permitted to enter that people need to work on. That you need to have a rule that says if you are suspect positive, you cannot come in. The next step on the flow chart is the one that includes that well-defined definition. So if you have a well-defined ambulatory care setting in a hospital, right, the outpatient wing of the hospital, where all employees are fully vaccinated and all non-employees are screened prior to entry. Keep in mind that's patients, contractors, volunteers, all the people are screened prior to entry. And that screening can be minimal. That can be, I've actually read that the screening of employees can be as simple as self-monitoring. Screening of non-employees, of course, because they won't have received the training, can be as simple as a few verbal questions. If they're screened and people with suspect confirmed COVID-19 are not permitted to enter, then the ETS does not apply. If not, continue on the flow chart. Home health care. Is the workplace a home health care setting? That means the medical support personnel go to a person's residence, to provide medical services. That can be either a occupational nurse, going into a residence, or it can be a somebody like an air gas rep, right? They assist that nurse by helping the individual with their oxygen tank. If it's a home healthcare setting where all employees are fully vaccinated, all non-employees are screened prior to entry, and people with suspected or COVID-19 are not present, right? So because it's a house, you can't prevent entry by a resident of the house. So basically you're asking for anybody inside the home, have they, experienced the symptoms, been in close contact, been diagnosed, all that stuff. So you need to make sure there's nobody present in the house who is suspect or confirmed. Then the ETS does not apply. Then we get into one that applies almost everywhere. Are there well-defined areas of the workplace where there's no reasonable expectation that any person with suspected or confirmed COVID-19 will be present? What are we talking about typically here? Non-public service areas, employee break rooms, storage areas, rear offices, places where you're able to control access, and you can be assured that somebody is not going to come in who is suspect confirmed. So just, I always like to remind people, this is more of a break room exemption. So if there are not that well-defined area, if you have a break room, but you don't have the signage, you don't have the training, you don't have the red tape line across the floor, however you've trained your employees to demarcate it, if it's not well-defined, your break room is just like any other area, and you got to comply with the ETS in it. But if you do have a well-defined area, where you've put up these signs, done this training, put up the tape, whatever it might be, that's where you make a split between your employees who are vaccinated and employees who are not vaccinated. Employees who are vaccinated in these well-defined separate areas don't need to face mask, don't need to have physical barriers, don't need to distance themselves. But if non-vaccinated employees are in these areas, they need to, of course, continue to wear those face masks, continue to distance themselves, continue to use physical barriers. So if you have an employee who's not vaccinated, they're going to be wearing their mask all around your facility. If you have an employee who is vaccinated, once they get back into one of these areas, they can kind of take a break, right? Take their mask off, socialize, all that stuff. So we keep saying all employees vaccinated, all employees vaccinated. There will be cases where some employees will not be required to be vaccinated. And that's a note that's actually in the ETS. So if you look at paragraph A2, this language is actually in the ETS. It's not hidden in some interpretive document somewhere. Employees who have medical conditions or religious exemptions don't count against you. So if you got 100 employees at your workplace, you got 99 of them who have no religious exemption to vaccination or otherwise any other good exemption, and one who does. 99 of your employees out of the 100 can be vaccinated, and you are treated as if all your employees are vaccinated. So this is kind of a nod to anti-discrimination laws. All right, so we've gone down the rule pretty well here. And what you're going to find is for healthcare who provide services to known suspect COVID cases, there's no way to get out of the rule. And for others who fail, in that flow chart in one way or another, you're still within the rule. So this is going to reach a lot of employers. It was mentioned that we may have some assisted living or nursing homes on the call who may not consider themselves traditional healthcare, perhaps. They fall within because they do have that nurse who is a medical professional, who does provide patient care, direct patient care. And they would have a duty. They would not be able to exclude known suspect COVID cases from their workplace. If a resident of your nursing facility, for some reason, maybe they had a visitation, maybe they went out on a trip, and they were infected, you're going to have to let them back in your facility. For those employers, you're the employer that the ETS was made for. And any employee who goes into those settings is the employer that the ETS was made for. So you can imagine right away, was this due for the United States Post Office, or a parcel delivery service, or these people who enter into these places? Well, they're not doing the screening, but they're going into the setting where healthcare is provided. Anyone who comes into the setting. And I think that warrants a little bit of discussion as well. What is a setting? Well, that's not defined. They give you a lot of definitions, but they don't really well define what a setting is. I would interpret it as certainly a room, certainly anywhere that the healthcare professional travels through. So if you have, let's say, we'll just stick with the occupational nurse because that's an easy one. If you have a nurse who travels through your facility, who visits patient rooms, visits the cafeteria, who may be expected to take vitals or do other professional healthcare services in various areas of your facility, anywhere that nurse goes is the healthcare setting. It follows her. The setting is where she provides the services, where she does her job. It's pretty much your entire facility. So you may want to incorporate some administrative controls, right? Such as isolation wings or limited service areas. We used to, provide these services throughout our facility. Now these services are provided at a central location, and residents or patients come to that central location. What does that do? That reduces the number of settings, right? And reduces the number of locations where this ETS applies, the emergency temporary standard applies. So the ETS has some flaws, in my personal opinion, in that it doesn't really cover some of the details that I'm concerned of as an industrial hygienist. I don't know if we have other industrial hygienists on the call today, but there's been a lot of discussion of aerosol transmission A lot of discussion of asymptomatic transmission of COVID-19. And I think the ETS kind of falls short of protecting against those. For example, there's sections in the PPE portion, the personal protective equipment portion of the rule, where it says in certain situations, face shields can be used in place of face masks, or in the physical distancing, physical barrier sections where barriers can be used instead of distancing. Barriers are kind of worthless against aerosol transmission. They work for droplet, but an aerosol by definition is able to take the path of least resistance and move through a barrier. So just be aware that this ETS probably has, in some ways, lower requirements than some of your other licensing or other regulatory criteria for your facility. But for other entities, it's more than they have done. Like I mentioned, that construction contractor coming into a hospital to do a project, or the equipment maintenance guy going into a patient room, to work on some equipment or take some equipment out or change a tank or whatever it might be. It's much more protective of them than any rules we had before. All right, so the ETS, if it applies to your workplace, there are requirements on employers to protect their employees. What is on this slide are the headings of the various sections of the ETS, but I'm going to kind of hop around on them because I think it's better to just kind of talk about what you should be doing from a immediate perspective. So if this rule applies to you, the first thing you should do is complete a hazard assessment that should be in writing and put it on file. If MIOSHA enforcement comes out to your facility, the first two things they're going to ask for are your hazard assessment and your plan. So to cover the hazard assessment first, there is a template on the OSHA website, but you don't have to use theirs. What you need to do is you need to look at your total employee movements. So not only their assigned job duties, but where they might go even predictably for non-assigned job duties. Where do their lunch, where do they congregate? Do they use a certain elevator to come in and out of the building? All that stuff. So you can use your own homebrew hazard assessment, or you can use a template one on the OSHA webpage. Get that done, get that on file. The next thing is your COVID-19 plan. So everybody who falls into the rule needs a plan, but the ETS puts different requirements on small employers than it puts on large employers. And this is the first example of that. If you have less than 10 employees, it doesn't have to be written. I would recommend that it still be written. But if you have more than 10 employees, that COVID-19 plan must be in writing. We do have a template plan on the OSHA website as well. That plan needs to incorporate not only your ETS compliance, your compliance with this rule, it needs to include compliance with any other requirements on your facility. So municipal, right, city township rules, county rules, licensing rules, they all need to be kind of cooked into your written plan. So everything that you're doing on site in one written program location. And you must engage non-managerial employees in that plan. At OSHA, we always talk about a safety and health committee that includes, line workers as well as management. So you kind of want to build this by committee, build it by consensus, and make sure that the direct patient care employees are included in its development. Then, after I develop my plan, once I get my plan and my hazard assessment on file, you got to designate your COVID-19 safety coordinator. Previously, underneath the old MIOSHA emergency rules, you needed one safety coordinator for each physical work location. Underneath the ETS, you can have a single safety coordinator who covers multiple locations, as long as those locations are substantially similar. And it's the same with your COVID-19 plan. Your COVID-19 plan can cover multiple workplaces as long as they are substantially similar. However, if you have very diverse operations, I would recommend you have a separate plan for each of your operations. If you have some hospitals, some urgent cares, some assisted living underneath the same employer. All right. Screening. I would set up my screening protocols next. So before we jump into screening, actually, I'd like to take a little side route here. Industrial hygienists always talk about the hierarchy of controls. Just like a medieval hierarchy or the hierarchy of angels, it's an ordinal ranking of power. And at the top of the hierarchy of controls for COVID-19 is vaccination. You want your employees vaccinated. That's the best way to protect them. After that, screening is your second best, because that prevents the exposure of employees to a single sick employee. Your third best control is distancing, right? Keeping employees as far away from each other as they can be. Your fourth best is ventilation, increasing the amount of fresh air. Excuse me, one moment. My apologies. The background noise was getting a little bit too much here. Home-based work. So where was I? Ventilation is your fourth best control because it should drastically reduce the amount of viral load in the air. If you look at the standard, they talk about using MERV 13 filters or the highest that your system can handle. Those are fine enough to really remove a lot of the droplets. And then finally, your worst level of control is personal protective equipment. We don't rely on PPE as a primary control because it can fail and the employee won't know it and the employee will be harmed. And they will be harmed without their knowledge. I'll talk about that a little bit more when we get down to respirators. So sorry for taking that little step aside, but I was speaking about screening. You need to limit points of entry into direct patient care areas, right? The places where these activities are taking place. And the reason that you need to limit points of entry, let's say that you have 3 doors into your patient care area, locking 2 of them and requiring everyone to come through a single door. The reason that we do that is to make screening effective so that you don't miss people when you screen them. By putting them through a single entry exit point, you're able to make sure your screening is effective. So you need to screen patients and all non-employees. That screening, as I said, can simply be a person verbally questioning them. It can be the form that we're all used to filling out now when we go to places, asking them the same questions. Or, what I always like to encourage people to do is a preemptive screening. Before they even come to your facility, have an administrative procedure where somebody calls them and asks them the questions. Don't even let them get to your front door. So that's your best way of protecting people. Who needs to wear face masks? If you don't feel like reading the rule, I'll break it down for you. Face masks need to be worn indoors and in vehicles with others, unless you're indoors alone in a room. It should sound kind of familiar, right? That's kind of what we had here in Michigan for a long time. So face masks for everybody indoors, unless they're alone in a room, and those in vehicles with others. What about respirators? What about filtering face piece respirators? Who wears those? Respirators are required for those with exposure to suspect or confirmed COVID-19. Exposure meaning in the same room or within 6 feet, okay? So non-direct patient care, who don't go into the room, who don't get within 6 foot of a known suspect person, face masks. Direct patient care, people who go into the room, people who get within 6 foot. And keep in mind that 6 foot rule, there's an exception for like brief passing, in the hallway or whatever. But people who need to get within 6 foot, they need to wear respiratory protection. Minimum N95, MIOSHA approved filtering face piece. And I will let you know from my personal preference, if you have somebody who is caring for a known COVID-19 person and they need to do some up close and personal work, they're administering medication or providing personal care services to somebody who's sick. I highly encourage a powered air purifying respirator like we saw in the beginning of the presentation. Not required, but encouraged by both me and in certain parts in the rule. We're not going to talk too much about aerosol generating procedure protective measures. Aerosol generating procedures are explicitly defined in the definition section as 7 different procedures. Essentially, if you do one of these procedures, and they're things like, intubation, that cause a lot of respiratory droplets to be expelled by a known positive case. If you're doing one of these aerosol generating procedures, you basically need what's called an AIIR, which is a negative pressure room for the patient to be cared for in. And we can talk more about what those look like if you do those procedures. Okay, physical distancing. All employers within the rule should require, encourage to the maximum extent possible their employees to maintain 6-foot distance from each other at all times. And if they cannot maintain that 6-foot distance at all times, maybe there's a nurse's station with 2 computers that are 4 foot apart, and for some reason you can't put them farther apart and they got to sit within 4 foot. You need that physical barrier between them. So your preference is distancing, your backup preference is barriers, and Tony, the CIH, is here to tell you that that barrier is really not going to do you much, if any, good, even though it's required. Disinfection. Cleaning and disinfection, the ETS basically adopts CDC recommendations. So you just follow the CDC, recommendations. One thing to mention is it is explicit if there's high touch surfaces, those are to be cleaned at least once a day. Doorknobs, countertops, things that everybody touches in the day. You must provide hand washing locations or 60% IPA rub, hand rub, hand disinfectant. That seems pretty straightforward to people. They're like, yeah, of course we have bathrooms, people can wash their hands in the bathrooms, but there's a lot of employees that do remote work. Okay, so if you have employees who are moving around, if you have like a guy in a truck driving around, if you have remote healthcare services, you need to make sure every one of your employees is going out there with the appropriate disinfection stuff for themselves, because you can't send a restroom with them. So that's an easy way to get caught by this rule. Keep an eye out for that one. Let's see here. Employee health screening and management. The ETS is pretty close to what we were doing in Michigan before, in the sense that you need to basically have your employees self-screen, do your own screening of your employees, have them notify you if they are known suspect COVID-19, remove them from the workplace. They're gone 14 days, or, if they get a test, and there's a lot of wrinkles to this one. I would encourage you to read it directly, because I'm paraphrasing it. But if they are gone at least 5 days, they can get a test and come back in 7 days. And then there's different rules if they were vaccinated, asymptomatic, or priorly ill, it might not apply. But basically, if somebody gets sick, you need to get them out of your workplace. You need to make sure that you notify, that they notify you. You need to make sure that they are properly removed. And then what's new in the ETS, and what a lot of people are struggling with, is there's a requirement to, if they are working remotely, continue their pay. But even if they're not working remotely, if they're too ill to work, if they're a known positive suspect, you need to continue to pay them up to $1,400. I believe that's a week. And that can be knocked down for different size employers, but you need to continue their pay for the entire time that they're out. And this is very burdensome for some employers, looking at assisted living, looking at home health care, looking at, places where employees may be incentivized to report symptoms or diagnoses that may not be true. Um, like I said, there was no cost benefit analysis conducted on this ETS. So cost to the employer, well, it was likely considered in the rule. There wasn't a notice and comment phase for people to state that this would be an issue for them. You need to, of course, well, I guess just to go down here. So vaccinations, the rule encourages vaccinations of employees, not only in its requirements for them in the workplace, but also, stating that employers must basically encourage their employees to get the vaccine, allow them to go on work time, pay them for their time to go get the vaccine. If they experience symptoms from the vaccine, allow them, pay them for their time to recover, all that. You must train, of course. Every OSHA standard includes a training requirement. So there is a template training on the federal OSHA website that you can use, a template PowerPoint that tells them about ETS, tells them about COVID-19, but it does not cover your precise procedures in your workplace. So you need to take that template and include in it what you do at your workplace for this stuff. Where do they get their vaccines at? Where do they go, to get tested? Where are your well-defined areas where they don't need to mask if they're vaccinated, et cetera, et cetera, et cetera. Where can they get their disinfectant? Who is your coordinator? All those things should be included in your employee training. You need to record COVID diagnoses, illnesses on a specified log. If you have more than 10 employees, that log is, we have a template log on the Fed OSHA website, I'll show you as well. That log needs to be kept but not submitted to OSHA. But what you need to report are fatalities and hospitalizations. So if you have a fatality or a hospitalization of an employee due to COVID-19, that needs to be directly reported to federal OSHA, not MIOSHA, federal OSHA. So let's see what we have here. Okay, we didn't cover that second point on the COVID-19 plan. Okay, so you did your hazard assessment, you identified the hazard, you created your plan. You want to say, our break room is a well-defined area. If you're vaccinated, you don't need a mask in that area. The employer must have a policy or procedure to determine the employee's vaccination status. OSHA did not give guidance on what this policy procedure to determine the vaccination status is. Certainly, you can ask for the vaccination card if you choose. What is not clear to me and what I would advise you to be somewhat cautious of is simply asking the employee whether they are vaccinated or not. I think that's probably going to be one of the first things that people get in trouble for, is relying on a verbal representation of the employee as to vaccination status, and OSHA maybe not finding that to be a good policy or procedure. I think we covered the rest of this. Okay, so what if your workplace isn't falling into the ETS? So you went on that flow chart, you took a look at it, you went down, you said, you know what, we're a hospital-based outpatient wing. We do whatever it is. Let's say we do, I don't know, surgeries, broken ankles and things like that, where we're a suite, a surgical suite, a non-emergency surgical suite. We do outpatient surgeries or radiography or whatever it is. We make sure that, nobody known or suspect comes in, and all of our employees are vaccinated, and we're out of the room. That does not mean you shouldn't do anything at all. It doesn't mean just stop doing anything for your employees. The top link here, OSHA guidance to protect employees from COVID-19 everybody should be following. It should. It is not law. Okay. They are recommended, right? And so are the DHHS recommendations, the CDC recommendations. These are all guidance. But I would remind everybody that there's still the general duty clause of the OSHA Act that says all employers must provide a safe and healthy workplace for their employees free from recognized serious hazards. COVID-19 is now a recognized serious hazard. If you're not doing what these documents say you should be doing, even if you're outside the ETS, you may face a general duty citation. And although I'm not going to give anyone any legal advice, and I don't, you could certainly face some civil liability as well. So I would take a hard look at that OSHA guidance to protect employees from COVID-19 and use that in any settings where the ETS does not apply. This was a flyby of the ETS. If you want more information, if you want more help from somebody like me, this slide tells you how to get it. So you can do what's called a request for consultative assistance by filling out an RCA form. And I'll make sure that Chow and Kelsey get a copy of these slides at the end of the presentation, so all you can get a copy. But you can hit that request for consultative assistance form link, and we'll come out to your site. We'll do a walkthrough. We'll talk to you. We'll spend a whole day with you working on this stuff. We'll review your plan. We'll answer any questions you might have in a one-on-one setting. Or if you don't want that level of contact, if you want an email or a phone call, you can do the Ask MIOSHA question form for an email. Send in a specific question. We'll send you a specific answer in writing you can put in your file. Or you can call the main phone number, ask us an informal question. We'll give you an informal answer, and you can work off that. We encourage everybody to sign up for our emails because that's how MIOSHA puts out updates to any rules we have for this stuff. If things tick up again, if we have a third wave of COVID, if we see the levels that we saw before, I don't think MIOSHA is going to stick with only the Fed rules. We'll probably put some more stuff into place again. And the best way to find out for that is to sign up for our emails. That second to bottom one, the Michigan COVID-19 Workplace Safety Resources, that's, then you guys have heard this guy, Sean Egan. That's all the stuff he talks about. So it's kind of a landing page for the DHHS epidemic orders, public masking orders, our emergency rules, anything that comes out from the state level. And then down at the bottom, there's the MIOSHA COVID-19 hotline. That's kind of hit or miss. It's kind of based on who you get on the other end of the line and how knowledgeable they are on this stuff. You might get somebody with zero experience in airborne infectious diseases, or you might get somebody like myself or Eric Zabin or somebody who knows quite a bit about airborne infectious diseases. So that's at the bottom because I would put it as a last resort. But if you want to give your employees something for them to call, if they have questions or anything like that, that's a good public phone number and it's constantly manned. Unlike the other stuff where you might have to wait a little bit for some responses, you call that number, somebody's going to answer it. So, a hotline, right? So they all have their own purpose. Just use the tool off this slide that best suits your need. All right. These are more additional links that are very useful. So a lot of the stuff I talked about in the presentation, that first one is a flow chart. The second one is the OSHA FAQs. They're minimal. They're good. I would recommend everybody review the FAQs. But the most frequently asked questions I get don't have answers on there. So it's kind of a misnomer. The FAQs that they have up there are just basically restatements of what's in the rule. They don't really expand on the rule that much, which is what I feel an FAQ page should do. I mentioned we have that template plan. Go ahead and download that, use it. The COVID-19 checklist and job hazard analysis, that's why I said should be the first step everybody should complete. I would print a copy of that and get it on file for your workplace. That PowerPoint presentation you can use for employee training is the next bullet point there. The COVID-19 healthcare ETS fact sheet is similar to the presentation I gave here, a plain language summary of the rule. Doesn't have a lot of additional information. And that bottom one, that's your catch-all. The COVID-19 guidelines, not rules, guidelines for all employers. That's for anything that falls out of the ETS. What should you be doing in those areas? I'd refer you to that document for that. Once again, this is MIOSHA's contact information. You have our physical address if you want to write us a letter or stop by. I don't think you can stop by, actually. I don't think they let people stop by in the current climate. But if you want to write us a letter, we have the hotline on there again. We have our CET phone number on there again, and we have our main website on there again. If anyone's trying to use the MIOSHA website, don't use the search function on there. Use what's called the A to Z index. And maybe if we have time, I can show you that as well. So that's the end of my presentation. I'll close out of here, stop my screen share. You know what, Chow, how are we doing for time? How much more time do I have?
Anthony, you just hit the 2:56 mark, so you do have 34 more minutes.
Okay, great. Well, let's maybe before we turn it over to Q&A, I'll just give you guys a quick web tour of the resources I talked about then.
Sounds good.
All right. So are you let me see. The best way to do this is probably just to share my browser. Where's my browser? Here we go. All right. All right. Can you guys see the browser all right?
Yep.
Great. So right here, OSHA.gov/coronavirus ETS is the main website for federal OSHA's ETS. So first things first, the Federal Register link right here. If you guys want to know more information than is in the body of the rule itself, I want to say there's about 600 pages of preamble where OSHA, states the grave danger, that the rule is necessary to protect, why the general duty is not good enough. And they also talk more about, why it's a settings-based rule, how they intend it to imply, what healthcare employers this was meant to protect. And that's really interesting because they include a lot of employers in there that wouldn't be considered healthcare if you were to look at their North American Industry Classification System code. So if you want more information, the Federal Register is very lengthy, but there's a lot of meat on that bone you can review. Up here is the actual regulatory text. And what a lot of people don't realize about the ETS is there's a couple different components to it. We just went over the healthcare component. There's also a mini respiratory protection program. And because we have the time, I'll speak to that informally for a moment. If one of your employees needs to wear respiratory protection, right? So they're doing direct patient care, they're exposed to known suspect COVID-19 patients, you need to follow our respiratory protection standard, meaning you need a written program. That employee needs to be fit tested, he needs to be trained, you need to do the full gamut to protect them. The mini respiratory protection program is for ease of compliance underneath the ETS for employees who would have been required to wear a face mask normally, right? So they're indoors, they're in shared areas, they're sharing a vehicle, but they want to wear a respirator. You have to allow them to do that now. It used to be employers could say, no, you don't need a respirator. I'm not going to let you wear a respirator. You have to kind of let your employees step up their respiratory protection now, but you don't need to give them all the same requirements. So the mini respiratory protection program, just like it sounds, has lower requirements than a formal respiratory protection program. The main thing that it does is, once again, for employees who don't need to wear a respirator, but who choose to, it removes the fit testing requirement and allows employees to simply move ahead with what's called a user seal check. The cornerstone of respiratory protection is that respiratory protection that's not fit tested to an employee is of limited to no value. The mini respiratory protection program kind of ignores that and says an employee can simply do a seal check, and that's good enough, to make sure that they can wear that respirator. So as a CIH, in my personal opinion, it's my position that a non-fit tested respirator is of questionable, if not zero, worth to an employee. So I have some issues with the mini respiratory program, but it's there. And the reason it's there is to decrease the burden on employers with compliance with the rule. Severability, that's just a legal clause that says if, for example, one of these provisions is challenged in court and found to be unnecessary or not appropriate or whatever, and has to be removed from the standard, we don't need to knock out the whole standard. We just knock out that one section. It's severed and the rest keeps effect. And 509 is another piece of legalese, incorporation by reference. So if they talk about CDC guidance for maximizing, availability of respirators, that kind of cooks it in, or where they talk about respiratory protection programs and they reference the respiratory protection standard, it kind of cooks that in as well. So just going down here, I have not seen this webinar. Oh, it looks like I have clicked on that. Okay. So I guess I have seen this webinar, but this is maybe then, yeah, I think this is probably the 1.5-hour review webinar provided by Fed OSHA on their rule. Should be a little more in depth than what I did today. They probably go into, for example, each of the exemptions in great detail. They talk about the various requirements for, how long you need to pay employees for, or things like that in great detail. They probably give equal airtime to all parts of the ETS, which I did not do. I kind of highlighted it for you. So go ahead and read, listen to that for more information. The fact sheet is a good thing to, review on your own. It's available in English and Spanish. This fact sheet on the mini respiratory protection program has a great chart on its applicability, where the old rule applies, where the new one applies. This is a flow chart that we reviewed in the PowerPoint. These are the frequently asked questions. The executive order is just the statement from Joe Biden basically saying, we need a rule on this. This is your written program template. So remember, if you have more than 10 employees, you need a written program. So that's a Word document you can change and modify to make work for your facility. This is a job hazard analysis. That is the form you would complete to determine, whether or not, or rather which of your employees and where in your facility they have exposure to COVID-19 hazards. This is the COVID-19 log. Once again, if you have more than 10 employees, that's the form you need to just kind of have on hand, have available, to show that you are recording any COVID-19 cases in your facility. Keep in mind, you need to report this next one, fatalities and inpatient hospitalization. So if you have questions about how to report, this is your resource for that. I don't know what the employer notification tool is. I should have looked at that. Communication and coordination between employers. There's a lot of settings your employees may go to where you don't have control over what they're doing. Your employees may go to another facility, and you have a duty to make sure that where your employees go in other facilities, that facility is complying with the ETS as well. So this gives you some information on how to do that, how to exchange written programs, how to verify. Maybe if most of your employees' time is spent at your facility, but they occasionally go out to a sister facility or an unaffiliated facility, how to protect them. Removal and return to work flow chart. That's probably going to be of great use to you guys. That lets you know kind of what to do stepwise from an employee notifying you that they have a known suspect case. You know, they answer the questions wrong. What do I need to do? That is a flow chart that you can follow for each scenario. This is the PowerPoint presentation on the ETS I referenced. I find it very good. You just need to make sure that you do more for employee training, like I said, including, you know, the details of how your program works. If employees have questions on the mini respiratory protection program, you know, their ability to wear respiratory protection when not required, or what they need to do to safely wear respiratory protection according to the ETS. This is a good presentation PowerPoint for that. If you want to know what MIOSHA or federal OSHA officers would do upon arriving to a facility, you can read the inspection procedures. But I'll tell you, the first things you're going to ask for are your plan, your hazard assessment, and your training records. And if you're a big company, maybe your log, right? They're going to start with the written stuff before they go anywhere else. So it's a little form over function-y, and I don't like being that way, but it's very important to have your written documents completed and good to go, you know, because like I said, if they're the first things that the guys ask for and you don't have them, that's a bad start. If they're the first things that the enforcement officer asks for and you do have them, that's a good start, and you want a good start with enforcement. So that's it for the Fed website. Now, keep in mind, all of the resources interpreting the ETS will be on that Fed website because it's a federal rule. The OSHA my OSHA website is up here now, and I'll let you know our website's a mess. The last thing that you want to do is hit the search bar and try to find something. This is the A to Z topic index that you want to use. Just click on that on the left. And it'll open a plain language directory. I don't think we have a section for COVID, but we'll find out. C for COVID. COVID-19. So it looks like we only have the main landing page here. So you click that, it'll take you to the Michigan landing page that I linked in my presentation, where it has the HHS rules, the written preparedness plan, all this stuff resourced into it. So you can access the OSHA resources from here, CDC resources, but here's the issue. The guys who operate these pages aren't as knowledgeable as they should be. So you can hit it here. I just want to make sure. Okay, good. Okay, so it is updated. So basically it just says, yeah, we adopted the Fed OSHA rules. I was worried it was going to open up our old emergency rules because that's what it used to do for a while. So you can get that Word document plan here. You can get resources. You can find out about what citations were given out if you're, you know, curious about that stuff, if you want to see who's getting dinged and for what. All of our resources are on here. But like I said, just keep in mind, it's a kind of a federal standard. So in case I wasn't clear earlier, any different rules from MIOSHA related to COVID-19 have been removed, rescinded, are gone. The only rules that we have in place are the same as the feds. We are lockstep with them. But yeah, so this is our webpage. Just thought I'd show it to you guys. I don't think there's much else on here to show you. The big burden, and I think most healthcare employers should have been through it by now, but if you guys aren't, you know, we can certainly talk about it, is respiratory protection programs. So I'll just take a little detour down that. So A to Z topic index, always start there. Respiratory protection are right here. publications, right here, publications for respiratory protection. Click on that, and that will take you to our various resources associated with the standard. So you can have our sample written program. The small entity compliance guide is a great resource for people who are not familiar with the standard to get up to speed. We have training videos on here. And if you want to take a full day course from somebody like me on the respiratory protection standard, we have the MIOSHA Training Institute, and you can find a class and attend a full day class on it. I would say most large hospitals probably had programs already in place, but I would think that a lot of small emergency care facilities, medical transport facilities, assisted living or nursing home facilities probably didn't have a written program before the pandemic. And, over the past year and a half, they've needed one. So if you don't have one of those up, and remember, the trigger for needing one of these respiratory protection programs is one of your employees needs to wear a respirator one time. So the bar is very low to get all this stuff up to speed. So if you need help on respiratory protection, we're your guys. Use all those resources that were in the end of my presentation to reach out to us. So I know that was a pretty fast run through, but I think that's probably a good spot to leave it. I feel like I've put a lot of my side of things out to you guys. I'd like to open up for Q&A now.
Well, thanks, Tony. There are a few questions in the chat, and I can just read them off to you.
Sure.
The first question comes from Lynn Ryder. Will you clarify if fully vaccinated sites include sites that have most vaccinated and the remainder have religious or medical exemptions?
That is correct. I can confirm that. Yes. It doesn't even have to be most. If for some reason, 99, I'm sorry, I don't know which religions have exemptions. I'm going to say Mormons, maybe. I'm sorry, I'm not good at this, but if most of your employees are of that religion, you may not even have a majority, just to clarify the statement there.
Our next question, do you need to report COVID deaths and hospitalizations of employees who were not exposed at work?
I would. So how are you going to show they weren't exposed at work, I guess is my question, because if you fall within the ETS, you have documented exposures at your workplace. So how are you going to show that that was not the cause of their illness?
Do unvaccinated employees need to wear N95 regardless of direct contact of known COVID patients?
Depends on what the employee's job duties are, whether they are in close contact, or I shouldn't use close contact, they don't use it, whether they are exposed to the individual. So for some employees, yes, for some employees, no.
What is the applicability of the ETS to volunteers, for example, training section? OSHA inspection guidance excludes unpaid volunteers in the standard, but MIOSHA historically includes volunteers in some capacity.
Yeah, is that my buddy from Spectrum Health? We got a question. We got a question just like that going up to our appeals division right now for clarification. We discussed that internal in my group, and we weren't able to find clear guidance. So it's a very interesting question, and it's a very apt one. That one I don't have an answer for at this time, but we are having internal discussions on that exact topic. Just to kind of flesh that out, it was always my understanding underneath, like I said, the federal system, we have a state plan state. We can be more protective than Fed OSHA. For example, we have the MIOSHA Act, which is more protective than the OSHA Act. So this is really a very tight legal question on the scope of the MIOSHA Act versus the OSHA Act. And I don't feel confident giving an answer to that one.
Thanks, Tony. And then at what point does an embedded healthcare facility in a non-healthcare facility become a healthcare facility with well-defined areas where suspected or positive COVID cases will not be present? 50%, or do we use any other indicators?
One more time on that one, Chow.
Yep. So at what point does an embedded healthcare setting in a non-healthcare facility become a healthcare facility with well-defined areas where suspected?
All right, stop right there. Embedded healthcare facility become a healthcare facility?
Yeah, healthcare setting in a non-healthcare facility become a healthcare facility.
Immediate. Yeah, the setting is a healthcare facility.
Okay, so with well-defined areas where suspected or positive COVID cases will not be present. 50% or any other indicators.
All right, I'm still not clear on that 50% or other indicators. So typically, there's a FAQ on the Fed OSHA website on this topic where they talk about there's a manufacturing facility and they have an occupational health clinic in the manufacturing facility, and they make it clear that the rule applies within that clinic and not, for example, on the factory floor. And then there's the exemptions, right? So if you have a first aid responder providing medical services on the factory floor, that's not in the ETS. But if you have a licensed healthcare professional, like if the nurse goes out to the manufacturing center floor and provides CPR, first aid, whatever, that is a healthcare setting. I'm not clear on the percentages. That it might be better to have the person who asked the question. Okay.
Yes. Yeah. Thank you. Sorry, I know it's a long-winded question. So the question kind of came up because we have some facilities that, for example, might be primarily non-healthcare, might be mostly office setting, but maybe in a few offices or maybe one floor, they have some kind of consulting or direct patient contact.
Mm-hmm.
And so we're kind of wondering, like, at what point does the facility become a healthcare setting instead of just that embedded healthcare setting? So if it was a 5-floor building and it was all offices and the first floor was direct patient contact, that would kind of be by definition that embedded healthcare setting.
No, it wouldn't. No. So especially in the scenario that you said where it's the first floor, anyone on the other floors would have to access through the first floor.
Okay, what if it was 5th floor? Sorry, I just was.
Anybody going up to the 5th floor would have to pass through the first floor. So that wouldn't work. So that I would say that is the entire building or the entire operation, let's say, falls into the ETS. And then your question is can we call those other 4 sections a well-defined area? And the answer is yes, but the well-defined area doesn't get you out of the ETS. The well-defined area gets you out of masking, distancing, and barriers. So yes, you could say that one floor where the direct patient care occurs must fully comply, but then the remaining areas or remaining floors must fully comply with the exception of those 3 requirements.
Okay, understood. Thank you. And then just for additional clarity, if it was, one office only that had that.
Same thing.
So I guess I'm not understanding then what's the difference between the office rooms versus a manufacturing setting?
The difference is OSHA gave me a very specific exemption that I can hang my hat on for the manufacturing one, and they did not do that for the other one. There is an analogy. I see what you're saying. It is similar, but like I said, I can't. I have to be conservative in my responses in this forum.
Oh, totally understand. So it's, I guess, just the manufacturing facility example. Okay.
Or something that I can really analogize to that. And the one thing that I would point out maybe about the manufacturing setting clinic is man, this is really, no, I'm not even going to go that far. I'm sorry, Brenna. but yeah, good question. I see where you're going with that. I think that's the kind of question that needs to be answered, from Fed OSHA, and I'd encourage you to send that kind of question up.
Okay, thank you very much. Sorry, I know I've got these weird, complex ones.
No, that's good. It's good.
Great question, Brenna. And then, Brenna, did you have another question? Did you want me to read, or did you want to?
I can ask it. This is my last one that I have. So we had this one come up. Should our full hazard assessments be conducted in those shared healthcare settings? So if there's another controlling employer, is communicating our COVID-19 plans to each other sufficient, or should we be having someone go in there and conduct a hazard assessment, even though we might not really have all the answers?
Depends where your employees go. So your hazard assessment needs to cover, like I said, not only locations where employees have assigned job duties, but locations where they may, travel, congregate, where it's foreseeable they may go. So if you do have, and this is similar to a mixed care facility, a lot of residential care have, primarily residential and a very small, healthcare component to them. And you really need to look at the movement of individuals through your facility. So I would encourage you, to include them all, unless you can demonstrate that none of your employees, either for assigned job duties or predictable, they don't go use the vending machines down there, they don't use the restrooms there, whatever it might be.
Got it. Thank you. That's the plan. Just wanted to confirm.
Yep.
Thanks.
And then, Tony, we have a clarification from Michelle. Michelle asked to clarify, do unvaccinated employees have to wear N95 with all patient care, COVID or not, or only with positive or suspected COVID patients?
This is such a simple question, it almost threw me for a loop. All right, hold on. All right, let me get my head around this one. Okay, so the duty for respiratory protection is only triggered by exposure to suspect or confirmed COVID-19 cases. Did that answer the question? Did I get that right?
This is Michelle. Yes, actually, my boss was shooting me questions, so this is her question. So if a patient is he's confirmed negative, or they are not suspecting COVID, then the employee can wear a face mask if they're unvaccinated, correct?
Correct.
Okay, thank you. That does answer the question.
Okay. Man, I tell you guys, this is not, you never know which way the ball is going to come from when you're doing these things. You gotta come into them with your feet under you.
If there's any other questions, feel free to unmute yourself and ask Tony, or you can drop in the chat and I can read out loud. So that was the last question that I see in the chat, Tony.
Beautiful. Let's give them another minute or two. Just make sure that no one has any long ones that they're typing out.
I have a quick question. You clearly defined areas that were break rooms, where vaccinated staff could take off their mask and eat and speak to one another. But there's really no definition of how you want handled unvaccinated staff who need a place to eat and
yes, very astute of you. Yeah, how do you eat through a mask, right? So I would assume that the old guidance from CDC would apply here, which is, only as long as needed to drink, to eat, things like that. So if they're in the break room, actively chewing, swallowing, all that stuff, obviously can't do it through a mask. But if they're in the break room reading a magazine, talking with people, not eating, you should have some, hey, you got to wear a mask when you're not actively, blah, blah, blah. That's how I'd approach it.
Okay. And my second question is in regards to your statement that any employee must be accommodated if they ask for a higher level of protection. So if their risk assessment is that they only need to wear a surgical mask, but they say they want to wear an N95, are you saying that we have to supply an N95 for any employee who asks?
I believe so. It may be worth pulling up the mini respiratory protection program. If we're through the questions at this point, let me get that up. And what I'll do is I'll see if I can just pull that fact sheet up and show it to you guys, because I think that's pretty clear on this.
Because I think it should be noted that this does put us at risk for supply for those staff that must wear a 95 when they're caring for suspected or positive. And you are
Yeah,
actually
yeah, we need-
creating a risk factor for supply and demand.
Yeah. So sharing the same number of respirators means, yep, less stockpile for everybody. So that's a great point. You know, if you have any anticipation of need of respirators, you should be looking at, you know, stocking up a little bit more at this point. You know, when I was talking about getting a written program up, I probably should have mentioned that as a step, you know, people under the ETS should be taking as looking to, you know, assess need, maybe an employee questionnaire or something like that, number of employees, figure it out. But let me pull the,
Yeah, and I guess the problem that our particular organization is having is prior to the availability where N95s became available back in the December, January timeframe when that kind of broke loose and you could get N95s. We had proactively beefed up on our KN95s. So we literally have, you know, 7,000 KN95s sitting in stock. And
Yep.
we know that we can't mandate those for employees, but employees could choose to upgrade if they chose to from a surgical mask to the KN95 mask. But what I heard you saying is they are not being recognized as
as a face mask. Yeah, they're not even. So KN95s are neither respirators nor face masks underneath the ETS. But here's the thing. All right, I'm not even sure I can say that. Okay, never mind, I can't say that. Hold on, I'm gonna share out a PowerPoint here. Yeah, I would be really cautious of the KN95s. I really would. Hold on one sec. Share screen. PowerPoint. So many PowerPoints up. All right, I think this is the one. All right. Can you guys see this new PowerPoint?
Not yet, Tony. It's just okay, there we go. Yep.
Okay, great. So I'm just gonna get down here. So right here, the scope of the mini respiratory protection program, like I said, is only for those basically who want to use it in place of a face mask when a respirator is not required. You got to do seal checks and training, but you don't need to do fit testing. You don't need a written program. You don't need a medical evaluation. I want to find the part where they talk about needing to provide it. Reuse is kind of cool. I point that out. So if you're going, so just because we're talking about supply and stock and all that stuff, you know, if you have a limited amount of N95s available, reuse is permitted here underneath these conditions. So not visibly damaged, stored in a breathable, you know, paper bag basically for 5 calendar days between use. And you do a visual, you do a user check. I don't know what this bottom one says because my screen's over it, but it hasn't been used more than 5 days total is what I think it says on F. So these are the reuse conditions, you know, so you can put those in where people are following, you know, so if they're using a face mask and they want a respirator, you can reuse the respirator a lot. So I'd point you to this resource, you know, basically one respirator can be used up to 5 times if it meets the other requirements. Yeah, it doesn't talk about that. I'm real sorry. I'm gonna have to pull the rule up. Yep, sorry, guess it's not in this presentation. Yep, so I'm gonna pull up the regulatory text real quick for you guys because I think this is useful for everybody. All right. Just bear with me here. I'm getting to where I need to be in my browser and then I'll share it out to you guys. Nope, that's not it either.
Hey, Tony,
Yes.
we are hitting the 3:30 mark, so maybe you could find it and then share it with Kelsey and I, and then we could pass that along to all participants.
Yeah, that sounds
along
really
with-
good. I'll give you the regulatory site for that. But yeah, so the mini respiratory protection program does have that issue. All these issues, whether you have issue with, you know, the requirement to give a filtering face piece respirator when a face mask should be adequate in your opinion, whether you find the continuing employee payment to be, you know, leading to increased cost, whether you find the well-defined areas requirement to be unclear and you need more information. All this information, I would encourage you to share with your associations, you know, put together a position paper, put together a comment to federal OSHA. Because like I said, they didn't do the usual notice and comment procedure for this rule. And without getting too into politics, I've often found that centralized rulemaking is inferior to the input of a notice and comment rule. You know, they miss stuff. You know, two heads are better than one. So all these things that we're talking about, please, you know, share your thoughts with the regulator, because otherwise things are going to stay the same.
All right, well, Tony, thank you so much. We are at the 3:31 mark, and we really appreciate your time today. You know, great presentation and sharing your valuable knowledge and providing, you know, additional insights to our chapter on these specific ETS. And also, you know, taking the time to even providing a 30-minute question and answer session for us. And then for all the participants today, we will provide the slides that Tony shared along with the recording of today's presentation out to the members. So look forward for that email. And then if you have any additional questions for Tony, you feel free to email Kelsey and I, and we can pass it on along to Tony as well. So thanks everyone for joining today, and I hope you guys have a good rest of your Tuesday afternoon.
Thank you, guys.
Thanks, everyone.
Thank you.